Hello folks, welcome to the channel MediManiac. Myself, Hemant Chaudhary, a second year MBBS student from Patliputra Medical College, Dhanbad. In these boring times of quarantine, let's learn something about the coronavirus, specifically about COVID-19. Oh, that rhymed. So let's begin, chaps. The coronavirus, as you know, the coronavirus family is a large group of viruses. It causes illness in various animals as well as now let's learn something about its morphology. As we know that coronavirus is an envelope virus, it carries a crown-like papilloma spikes, giving the appearance of the solar corona, hence the name the coronavirus. It is a large virus with a diameter of 120 to 160 nanometers. It exhibits helical symmetry and has a positive sense, a single-stranded RNA. As you can see, it is a spike glycoprotein and it is the heme agglutinin esterase dimer. These are surface proteins, and here is the RNA that is single stranded and positive sense with embedded N protein. Now, after morphology, let's move to the classification. The corona family is named the Coronaviridae. It has two classes, the Coronavirini and the Torovirini. The Coronavirini has further four subclasses alpha, beta, gamma, and delta. Most of them infect the animals, but the gamma family infect the birds. Now, human coronaviruses. The human coronaviruses, till now, six coronaviruses infecting the humans have been reported. These are the human coronavirus 229E, human coronavirus NL63, human coronavirus OC43, human coronavirus HKU1, and the SARS coronavirus that was reported in the year 2003, the MERS coronavirus that was reported in the year 2012, and the SARS coronavirus 2 or the novel coronavirus that is reported in the year 2019 and is causing the disease COVID-19. The first two variants belong to the alpha subfamily, whereas the rest belong to the beta subfamily. Now let's learn something about the COVID-19 disease. As we all know that the origin of the COVID-19 disease was from Wuhan district of Hubei province from China. The timeline of the spread of disease is as follows. On 1st of December 2019, the first suspected case in Wuhan, China was reported. On 31st of December 2019, WHO alerted by the spike in the cases of pneumonia of unknown etiology. On 7th of January 2020, China named the virus as novel coronavirus. On 9th of January 2020, first death was reported in Wuhan, China. And on 30th of January 2020, first case was reported in India, and WHO declares it as a public health emergency of international concern. And WHO also termed the virus as SARS coronavirus 2. On 11th of February 2020, the WHO terms the disease as COVID-19, and recently on the 11th of March 2020, WHO declared it as a global pandemic. Now, according to the WHO risk assessment parameters, the WHO has categorized the risk factor in the China as well as globally as very high. Now, let's guess some of the basic facts about the COVID-19. The causative organism for COVID-19 disease is the SARS coronavirus 2 or the novel coronavirus. The source of infection is the case reported. The incubation period for the disease is from the 2.2 days to 11.5 days. The transmission can occur as a droplet infection or with a contact with a contaminated surface or via fomites. The overall case fatality rate is 2 to 3.7%. The fatality rate increases as the age progresses, so the fatality rate is more than 10% when the age is greater than 80 years. The case fatality rate increases with coexisting morbidities like hypertension, diabetes mellitus, cardiovascular disease, or respiratory disease. Now, how will you define the suspected case? A suspected case is defined as a patient with the acute respiratory illness, that is, the fever and at least one sign or symptom of respiratory disorder like cough or dyspnea, and with no other etiology that fully explains the clinical features of the patient, and the history of travel to or the residence in area reporting local transmission of COVID-19 during the period of 14 days prior to the onset of symptoms. The definition of confirmed case is that a patient with a laboratory confirmation of the COVID-19 irrespective of the clinical features and the symptoms developed. Now let's talk about the pathophysiology of COVID-19. As we have studied in the morphology that the virus particle has mainly a spike protein, but the most important of these is the S spike protein, and the genetic material of the virus is a positive sense single-stranded RNA. The transmission can occur in a variety of ways. Mainly, the transmission occurs by the contact of the contaminated surface by a healthy person. The virus could survive at any surface for at least 2 to 3 days. Another method of transmission is airborne. It could be airborne. The virus could be present in air for 2 to 3 hours after an infected person has sneezed or coughed in the open. Virus, after entering the respiratory system, enters the alveoli and attaches itself to type 2 pneumocyte. The type 2 pneumocyte generally does what? It produces a surfactant. A surfactant is chemically a phospholipoprotein. What it does, it reduces the tension along the alveoli and it decreases the collapsing pressure within the alveoli so that it prevents the collapsing of the lungs. Now, the virus, as we know, has specific S spike proteins. Now, assume this is the structure of a type 2 pneumocyte. The virus, as we know, has S spike proteins. These S spike proteins are present on surface of the virus, bind to a specific receptor present on type 2 pneumocyte. This receptor is angiotensinogen converting enzyme 2. This binding of virus with the angiotensin 2 converting enzyme to receptor produces what? It produces the release of various single-stranded RNA into the cytoplasm of the type 2 pneumocyte. The single-stranded RNA can do a couple of things in host cell. First, this single-stranded RNA can bind to the ribosome of type 2 pneumocytes. And what we all know that ribosome does is it causes translation. Translation of this single-stranded RNA of the virus particle produce a variety of polypeptides. Now another thing that
Now, the single-stranded RNA of the virus can also produce abundant single-stranded RNA molecules with the help of RNA-dependent RNA polymerase. And the polypeptide produced as a result of translation could undergo proteolysis with the help of several proteinases. And they produce several enzymes, nucleocapsid protein, and spike proteins. The newly formed single-stranded RNA and these products of
we can say
proteolysis.
single-stranded RNA molecules and the product of proteolysis combine together to synthesize new virus particles. These virus particles are transferred to various types of cells throughout the body. Now, during this process, the pneumocyte cell get injured. This stimulates the pneumocyte cell to secrete several inflammatory mediators like interleukins, TNF, and various cytokines. These mediators stimulate the macrophage. Now, the macrophage releases several other specific interleukins like interleukin 1, interleukin 6, TNF alpha. Now, these interleukins and the TNF alpha produced by the macrophage increase the permeability between the endothelial cells, and because of increased permeability, they are transferred into the bloodstream. As we all know that these interleukins and the TNF alpha causes vasodilation in the vessel as well as increases the capillary permeability. The fluid release through the leaky capillaries into the interstitial spaces. So let's notify this fluid. Now the fluid gets accumulated and the leakiness allows the transfer of fluid into the interstitial space or around the alveoli. Now this fluid slowly accumulates around the whole of alveoli. So with the course of time, the capillary permeability increases more and more. So more and more fluid accumulates in the interstitial fluid and around the alveoli. And after a point of time, the fluid tries to compress this alveoli, and due to increased pressure, the alveoli gets contracted. It loses its shape, and the gaseous exchange is also hampered. Now we'll see how. There is increased alveolar edema. This drowns out the surfactant. So as we all know that surfactant was responsible for the surface tension. So surface tension increases. By Laplace law, we know that the surface tension is directly proportional to the pressure. Here the pressure is the collapsing pressure. As a result of this, the alveoli collapse. As the alveoli is responsible for the gas exchange, there is a drastic decrease in the gas exchange. And this has several other implications. Gas exchange is reduced. It causes hypoxemia, which is another critical condition, and it also increases the work of breathing. The work of breathing increases as the person needs to work extra hard to reopen these alveoli against the force of fluid accumulated around it. And if it worsens with the course of time, it could lead to acute respiratory distress syndrome. Now, this increased work of breathing would present itself as the clinical feature of dyspnea or shortness of breath. Now, as these inflammatory mediators are increased within the alveoli, they also bring in several other neutrophils. That this is alveoli. These are neutrophils. These neutrophils try to phagocytose this virus. So, in order to damage this virus particle, the neutrophil releases reactive oxygen species and proteases. These reactive oxygen species and the proteases damage the alveolar cells. The alveolar cells, as we know, are type 1 pneumocytes and the type 2 pneumocyte. The type 1 pneumocyte are responsible for the gas exchange, and type 2 pneumocyte releases the surfactant. So, as more and more cells are killed within this alveoli, cellular debris start to accumulate within the alveoli. There are several other cells, the macrophages, neutrophils, the debris of type 1 pneumocyte, type 2 pneumocyte debris. This causes consolidation of the alveoli. This consolidation also reduces the gaseous exchange across the alveolar tissue and leads to hypoxemia. More and more fluid, the cellular debris, as well as the type 2 pneumocyte and type 1 pneumocyte cell debris within the alveoli accumulate, and as it gets severe, the person might feel uneasy to breathe. As these products accumulate, the person might feel the urge to cough. As the consolidation becomes more severe, the person coughs repeatedly. This would present as a clinical feature of dry cough. Now, with passage of time, more and more interleukin 1-6 and TNF alpha would accumulate within the bloodstream. As more alveoli are affected now, the more increased this interleukin and the TNF alpha would stimulate the CNS. In CNS, it stimulates the hypothalamus. The hypothalamus gets activated and releases specific prostaglandins like prostaglandin E2. Now, these released prostaglandins would reset the thermostat. This would increase the body temperature, and we get another clinical feature of fever, which is important in the diagnosis of coronavirus infection. Now, as the gaseous exchange decreases across the alveoli, the level of oxygen within the blood also decreases. This decreased PO2 within the blood stimulates the chemoreceptors present in various cells. This would stimulate the sympathetic nervous system. As we know, the sympathetic nervous system is stimulated, it would increase the heart rate, presenting another feature of tachycardia. The stimulation of the sympathetic nervous system also increases the respiratory rate, as the person would try to cope up with the reduced gaseous exchange. Now, as the inflammatory response within the alveoli becomes more and more severe, it may lead to SIRS. What is SIRS? SIRS is systemic inflammatory response syndrome. Systemic inflammatory response syndrome, the more and more interleukins and cytokines accumulate throughout the circulatory system. These increases the capillary permeability throughout the circulation. So, as a result, the plasma leaks into the interstitial spaces. This causes decrease in blood volume. Let us learn it systematically. The SIRS would increase the capillary permeability throughout the circulation. This would decrease more plasma leakage into the interstitial space, so the blood volume decreases. These mediators would also cause vasodilation of the systemic vessels. This would decrease the total peripheral resistance of these vessels, and this decrease in blood volume and the decreased total peripheral resistance would lead to hypotension. This hypotension would mean hypoperfusion of various tissues. It would affect various systems, but mainly the renal system. The leakiness of the glomerulus increases, which would mean there is increase in the total BUN as well as increase in the creatinine levels. Liver is the other organ affected due to this. Liver, as the inflammatory enzymes increases, These enzymes are ALT, AST, and serum bilirubin. As a result of inflammatory response, the acute phase reactant proteins also increases. Example of these are C-reactive proteins, fibrinogen, and interleukin 6. Now coming to the pharmacological aspects of the COVID-19, we must understand that no specific drug therapy has been approved by FDA till now. The most important aspect right now is the prevention of disease. The prevention can be achieved by the practice of social distancing and isolation. The drug therapy that is constituted nowadays for the treatment of COVID-19 is as follows. Two antiviral drugs like remdesivir and favipiravir are specifically used for treatment of the COVID-19. The mechanism of action for these is they both inhibit the RNA polymerase of the coronavirus. As we have studied the pathophysiology of the COVID-19, we know that RNA polymerase is responsible for formation of new RNA particles that increases the virus particles within the body. The patient of COVID-19 was also treated with the combination of drugs. Patient of like COVID-19 is treated with combination of drugs like antimalarial drug, hydroxychloroquine, drug used for the treatment of swine flu like oseltamivir, and protease inhibitors like lopinavir. That's all from the pharmacological aspect of the coronavirus. Now the question arises, how will you diagnose the patient of COVID-19 disease? The first thing that a clinician must observe in the patient of COVID-19 are the clinical presenting features. The clinical presenting features that were talked about in the pathophysiology of the disease are the high-grade fever that is greater than 100 degree Fahrenheit, a dry cough, and shortness of breath or dyspnea. These are highly specific clinical features that must be kept in mind while dealing with the patient of COVID-19. The specimen collected for the further detection are nasopharyngeal swab, the oropharyngeal swab, and these must be synthetic fiber swabs with plastic shafts. Sputum is also collected for detection. The investigation of choice for the COVID-19 disease is RT-PCR or the reverse transcriptase PCR. It is done to detect the N gene and the E gene. These two genes are responsible for the screen. Sputum is also collected for detection. Now coming to the investigation part, the investigation of choice for COVID-19 is reverse transcriptase PCR. It is done to detect the N gene, the E gene, and the RNA-dependent RNA polymerase. The N and E genes are highly specific for screening of any bat-associated beta coronavirus, and the RNA-dependent RNA polymerase is specific for SARS-like disease. The nucleic acid amplification test can also be done, but it is highly expensive. So, the investigational choice for the COVID-19 disease is RT-PCR. The viral signs are the increased heart rate, increased respiratory rate, and decreased PO2. The serological signs. The serological signs of after doing the CBC, we find that the patient is suffering from lymphopenia. It also affects the liver. So in liver, when we do the LFT test, there is increase in AST, increase in ALT, and increased bilirubin in the plasma. Due to hyperperfusion of the kidney, there is increased BUN and increased creatinine in the plasma. If a COVID-19 patient also suffers from bacterial superinfection in the lungs, then there is increased procalcitonin levels in the plasma. The other markers are the inflammatory markers. These are increased C-reactive protein, increased ESR, and increased interleukin-1 that was released from the macrophages. The other specific test for the COVID-19 detection are chest X-ray. In chest X-ray, you see that there is ground glass opacity in the lower lobes of the lung. You can easily see here that there is ground glass opacity present in the lungs. We also do CT scan. It is the most sensitive test for COVID-19, but it is not specific. It can occur. It can be The other tests we perform for COVID-19 detection are chest X-ray. In chest X-ray, we found that the ground glass opacity is present in the lower lobe of the lungs. You can clearly see the ground glass opacity in the lower lobes of the lungs. The other test is the CT scan. CT scan is the most sensitive test for COVID-19 detection, but is not specific. In CT scan, you also see the ground glass opacity and there are areas of consolidation. Now coming to ultrasound, when you do a lung ultrasound, we find that there are present the pleural thickening line, and the B lines also increase. The B lines are increased as you can see clearly in this diagram. The signs of consolidation are also seen through the ultrasound.
So that's all for today, folks. If you like the video, press the like and share button and subscribe to the channel.